He has published well over 100 peer-reviewed scientific articles and serves as the specialty chief editor for Population, Reproductive, and Sexual Health, Frontiers in Public Health, and Frontiers in Medicine, an open access peer-reviewed scientific journal. And he's done an awful lot of work with Dr. Thomas Hilgers and his leaders as well of the Creighton model. So I welcome Dr. Joe.
It's a real honor to be here. I appreciate being invited. As Teresa mentioned, I'm not Roman Catholic, but Humanae vitae has had a great impact on my life, and I'm pleased to be a part of this group today. This is the summary of my state of the science. And so you could take that, and we're kind of summarize it right there. I want to talk a little bit about use of NFP in the U.S. and around the world, some about the effectiveness for avoiding pregnancy, effectiveness for conceiving, a little bit about subfertility, impact on health and relationships, and then just a word or two about the future. That's a lot to cover in a short time, but I wanted to give an overview of the whole spectrum of NFP science, not just one piece of it. So that's my attempt to do that today. In terms of use of natural family planning, Richard mentioned it's less than 1% using modern methods. If you include rhythm, and some of that is dubious in terms of how well it's understood and used, 2 to 3% of women in the U.S. are using some kind of natural or fertility method of some sort, including rhythm. It's you can see that it's not the people that are not reflective of the U.S. population generally. They're married, 2/3 married, more likely to be Hispanic, Catholic, more likely to have religion be very important in their life, and more likely to be open to pregnancy. So that they're a different group of people than the general population. About worldwide, it's a similar population, similar to 3%. It varies, of course, by country and region. One thing that we need a lot more data about are mobile applications, mobile phone apps, because those are exploding. A lot of them are not very good, but a lot of women are using them, and we need to know a lot more about who's using them and in what ways. I just anecdotally, I've done a number of studies, but 2 studies of multi-center studies, the Creighton model. I did one before around 96 to 2000, another one in 2009, 2011, about almost 20 years later. We found that there's a shift over time in the Creighton model, the number of couples learning it right off the bat, trying to conceive. And it went from 19% to double that. And studies I've and other people have done about interest in natural family planning among those who are not already using it show that the interest is higher for trying to conceive than to avoid. So now let's talk about effectiveness to avoid. I've been part the last couple of years of a systematic review team to look at this question, what the evidence currently is available for specific fertility awareness-based methods to avoid pregnancy as measured by unintended pregnancy rates, which is not a perfect measure, but it's the measure that's out there, so we are assessing that. It focuses on new users in the first year, and prospective, both typical, meaning all the users, all the women or couples in the study, and perfect use as those who use it consistently, correctly. I'm not going to go through all my colleagues on this on the study. I'll say we represent a variety of both scientific disciplines, but also ethical or ideological perspectives. And to me, that's a valuable thing to work together to try to figure out the best evidence across different perspectives. There's a couple, at least one of the group is Catholic, and maybe 2, I'm not sure. So this systematic review group is a protocol. We developed a protocol that we registered in advance. That's the current standard for systematic reviews, and did a systematic search across a number of electronic databases for medical literature. We came up with a formal quality framework for the research question. That's important. This is specific to this question of unintended pregnancy. And these are 13 criteria. So if a study doesn't make a certain level of quality for this research question, it doesn't mean it was a bad study. It just meant it didn't answer this question the way we were looking at it. These criteria there's too much detail to go into them for you today, but that will be coming out, and it's also, I can send you more details individually if you're interested. Each of these studies were reviewed by at least 2 team members independently, and then we resolved conflicts together or through the group. So these are the studies that we've looked at. With the quality criteria, we ranked each study as high, moderate, or low. And we had about 50 studies. It turned out that none of the studies hit high quality, including the couple I did. None of them got to the high quality ranking, again, for this specific question of unintended pregnancy. So these are the studies by method. You can see the standard days, calendar rhythm. None of those got to moderate quality. The crate model studies I was involved in were judged not to address the question of unintended pregnancy, they address other questions. 2-day method, Billings ovulation method, basal body temperature, symptothermal, and then the specific symptothermal method known as Sensiplan, Marquette, and others. This is our, and I'll let you memorize this for a minute. This will be coming out for those who want to look at all the details, but let me just point out a couple things. The lowest typical use pregnancy rates, that's all users, all new users over a year time. So pregnancy rate per 100 women years. The lowest come out of the Marquette studies, some of the Marquette studies, and the Sensiplan out of Germany and Europe. And then we have sort of intermediate rates. These are all about under 2%. And then this is a 10% mark, somewhere around the 10%, 10 to 20, 10 to 15% for the Georgetown standard days and 2-day studies. And then for billing studies, it's a lot more variable. Some are pretty low, some are pretty high, and I'll come back to that a little bit. What is that variability? Is it about the method, or is it about who we're studying? And then same thing with symptothermal. There's a range, other than Sensiplan is in the low, and then the other symptothermal studies. Now we're on a different scale for perfect use pregnancy rates. This is the pregnancy rates for people who use the method consistently and correctly to avoid and don't, quote, take chances or whatever you want to call the term of not using it consistently, correctly to avoid. This is a different scale here. So now we have 15 per 100 women years here, 10, 5, and 0 here. And you can see, again, the lowest ones are the Sensiplan under 2%, and one of the Marquette studies at 0. And then the lowest billing study is at about 3% here, a little under. And then you have some of the other, again, the standard days 2-day method here in the under 5% range. So our conclusion from this is there are no high quality studies, some moderate quality studies. The typical use pregnancy rates, which are based on the concept of unintended pregnancy, are a wide range for across all the methods. They range from 2% to 30+%. The perfect use pregnancy rates are all under 5% for, and some are under 1%, except for the persona, which is kind of a special case, and some are under 1%. I want to give 2 important caveats to understanding these data. Typical use pregnancy is a range, and it's affected not just by a method, but by the demographic relationship and motivational factors of those using the method. If you're studying a bunch of people at the beginning of their reproductive lifespan who are very open and interested in pregnancy, you're going to get a very different typical use pregnancy rate than if you study, and I'll show you a study representing that issue. And then unintended pregnancy itself is a heterogeneous concept that is the concept people use in the family planning contraceptive literature. So it's important to do that for comparison relationship relating to it. But it's also important to understand that it does not capture the whole reality, especially of natural family planning use. So here's a very old study by John Marshall that Dr. Faring mentioned, Dr. Marshall's early work for the basal body temperature method, but it illustrates very nicely this issue. These were women using the basal body temperature method of NFP. And you can see the pregnancy rate for those that were 20 to 24 was 28.3 per 100 women. And then the pregnancy rate for those who were 35 to 39 is 0.8, under 1%. This is not all biology. This isn't women just getting less fertile as they get older. This has to do with their level of motivation and behavior. These women also had, on average, about 3 prior children. So this was not, this is a stark demonstration of how the actual characteristic of the users affects the pregnancy rate more than the method itself. That's a really important concept. Also, the concept of unintended pregnancy, from the National Survey of Family Growth, there's a question that classifies pregnancies as mistimed, and unintended pregnancies are classified as mistimed plus unwanted. We'll go into those measurement questions, but we did a qualitative study of this a few years ago, and these are 4 different women. They all had a mistimed unintended pregnancy, but these are their quotes about the pregnancy. The first one, we planned it. We weren't expecting it quite so soon. That's why the questions classified it as unplanned. We planned it, but we were hoping for it, so it came as a very pleasant surprise. We were very excited. The second one, I have mixed emotions. We had tried, so I guess in a way it was planned. I would just say to him, I want a baby, I want a baby. The third one, we were shocked. I just thought the birth control would work. And the fourth one, it isn't wanted, I'm getting rid of it. So these are all unintended pregnancies, but they're very different circumstances and reactions. So whenever you see that term unintended pregnancy, you just need to know that it's not, there's more under the surface, and it's a heterogeneous group. One other thing here, it's pregnancy rates in a randomized trial to illustrate the issue of how unintended pregnancy is complicated. So this is from Richard's study, Dr. Farrington's study, one of his randomized trial he did of a mucus version of the Marquette system and a monitor-only system. I'm not so focused on the specific methods here as the principle to illustrate. So in each is a randomized trial, so the fairly even number of women analyzed. The perfect use pregnancy rates, 100 women, 2.7 for the mucus, only 0 for the monitor, and these were not statistically different. The typical use pregnancy rates, and that's, again, at the beginning of each month, just stating whether they're intending to get pregnant that month or not, or that cycle. Roughly 18% for the mucus group, 6 or 7% for the monitor, so roughly almost 3 times as much in the mucus group. But then if you look at all of the pregnancies, this is intention to treat analysis includes all the pregnancies, which includes the intended pregnancies. They're not that different. And so the question is, did the people in the mucus group just happen to have a bunch of unintended pregnancies, but not so many of them wanted to get pregnant? And then the people in the monitor group, they didn't have very many unintended pregnancies, but there were a lot more of them that all of a sudden by chance wanted to get pregnant and said they had an intended pregnancy. Or is there something else going on that's a little more complicated here under the surface as to why people declared the pregnancies to be intended or unintended in advance? So I'll just leave that with you as this is why that if you're just looking at unintended pregnancy, you don't get the whole picture of NFP use in couples. So to summarize these complicated data area, do we have enough data to recommend the use of NFP to avoid pregnancy, or do we need more data with better studies? My answer is yes. We do have data, I think, enough to recommend it, but I do think we also need more studies. That's the half full, half empty. Okay, so let's talk about conceiving. This is a study from Boston University called Pregnancy Study Online. The PI is Dr. Wise. I've been involved in this study a little bit peripherally as a consultant. It's an internet-based study of women in the USA and Canada who have no prior history of infertility who they enroll in the study because they're trying to conceive. So the analysis I'm going to show you hasn't been published yet. It's over 4,000 women, mean age of 30, fairly highly educated. This is a study online, so they're all doing this study from around the United States and Canada. And so first I want you to look at the column on the left. This here, these are just women trying to conceive in the United States. There's nothing about them having necessarily been taught anything about NFP or fertility awareness formally. So this 22% are using basal body temperature when they come in the study. 40% are doing some kind of observation of cervical fluid. This surprised me a lot. About 12% report they're doing self-palpation of the cervix, or trying to at least. 32% doing some kind of urine, that one didn't surprise me, urine ovulation testing. 62% some kind of charting, 50% almost counting days, cycle days. So 75% are doing something. They're trying to conceive. Obviously these are women a little more motivated, they're in a study, They're trying to conceive. They don't have a history of subfertility. And they're trying, 75% are doing some kind of one of these things to try to help them get pregnant faster. When we compare them to those who are not doing that, this also surprised me a little bit. All of these came out really pretty much in the same ballpark in terms of the fecundability ratio means how much quicker do you get pregnant. So you get pregnant, you can kind of think of it as getting pregnant 26% faster or 28% faster. In all of these, they're about the same, which again is a surprise to me. So there are multiple other observational studies that have found shorter time to pregnancy with different types of NFP or fertility awareness. However, I have to also mention, we don't have time to go into them, randomized trials have had mixed results, including one that I did. So this is another area where I think there's evidence that does help get pregnant faster, but we need more evidence as well. What about couples who have subfertility, also often called infertility? This is a couple's condition that is often seen as just difficulty trying to get pregnant. But I first want to point out that it has a whole bunch of other ramifications that need to be looked at as well. How healthy is the baby going to be? How healthy is the mother going to be in pregnancy and long term? The father. All of these things, there's research now being addressed to some of these things. Life course epidemiology, looking at what is the long-term health implications of these conditions, and can we, from my point of view, can we fix them early rather than just get somebody pregnant but perpetuate some problems in the next generation? So I'm going to show you 3 studies here. 2 of them I was involved with in NAPRO, and then one from Germany from the Census Plan group. So these are you can see for each one the number of couples involved, the time frame for follow-up of treatment. For the NAPRO studies, it's 2 years. For the Census Plan, it's a little under a year, 8 months. All of them have women about age 35 on average who have been trying for 3 to 5 years. The adjusted live birth rate for the NAPRO studies is 50 or 60 or 70, 65%. Heidelberg, they didn't do the live birth rate, they did the pregnancy rate. Now, I want to point out that the pregnancy rate is at 8 months, and the one for the NAPRO studies is 2 years longer time frame. So I think these are all in a kind of similar ballpark. And the other thing that I think is interesting is the low birth weight is very low compared to IVF studies where it's 30+%. And I think that's really important. Not just are you having the babies, but how healthy are the babies. So restorative treatment of subfertility has promising results. There are a few studies. I think overall the live birth rates are similar to couples who receive up to 3 rounds of IVF, but much healthier babies and of course much lower cost. Let's talk just a little bit about health. I just want to give a shout out to what I think possibly the single most important study published in the last century for fertility awareness, natural family planning, women's health. And this is describing the concept of the ovarian continuum that James Brown developed, who Dr. Faring mentioned. He is deceased now. From that women have the spectrum over their lifetime, from no ovarian activity to estrogenic activity by itself, and eventually the partial progesterone activity, then incomplete luteal phase, and then a fertile ovulatory cycle with a robust luteal phase. And then there's also the possibility sometimes of super driving the cycle with drugs, which is not, in my opinion, a desirable state, but it does exist. And then women go through these different states in their lifetime, starting from menarche into eventually fertile ovulatory cycles pretty quickly usually. And then through menopause, they kind of go back. And also around pregnancy, there's a transitioning between these different states. So this is, I think, just a very important conceptual framework for women's reproductive health that I think deserves to be, and fortunately was published in a very highly regarded mainstream journal, and I hope it continues to get more attention over time. Applications of natural family planning and fertility awareness to women's health are legion. Dr. Hilgers is an undisputed pioneer and leader in developing what he calls NAPRO technology to do this. Others have also been involved, like Pilar Vigil and some of her colleagues, and looking at the applications to endocrine disorders, both ones that are directly related to ovulation and those that are also not directly, but still affect the overall reproductive system. And then I put general categories: infections, inflammation, anatomic, autoimmune, endometriosis, which is in some sense relates to all of the above. These are all really important ways that NFP will allow women and health professionals and physicians to become partners in better addressing these conditions in a restorative way rather than a very ineffective, in most cases, ways that has been done in conventional medicine. So just one quick word about relationships. I think it would be remiss not to talk about the fact that natural family planning has a huge impact on the couple's life and their children and their families. And we need a lot more research in this area. There's a small body of research, and most of the good research, a lot of the good research has been by my colleague, Dr. Richard Faring. This is just one of his studies that looked at couples in the United States, every use of NFP. Now you have to, this is not, and never have use of NFP and the divorce rates. And this doesn't look like doesn't look like dramatic difference, but that is quite a big difference in a population-based study. This came out of the National Survey of Family Growth in the United States. And then also the risk factors, odds for divorce, if ever having had abortion and using the pill or having been sterilized. 2/3 the risk of a divorce if you're using natural family planning. 2/3 if you're attending church, which that's part of the difficulty. Can you, or even should you, try to disentangle those two factors? Obviously, there needs to be a lot. This is an area I think that is really wide open for some really good social science and qualitative research. In general, several studies show mostly positive impact, but they're small. Most of them have severe selection bias. This is a wide open field for more research. So just a couple words about what I think needs to happen in the future, what I hope to see happen in the future, and hope to be part of training future scientists to do some of this. So we've got again, this is half empty, half full kind of thing. We've got to just recognize kind of our context that we're in scientifically. This is, PubMed is the National Library of Medicine search database for medical records, for scientific medical studies. If you use the term natural family planning, you have 484, this is of a few days ago, 484 studies published indexed under that term. For contraceptive agents, it's about 100 times that, okay? Natural procreative, just as a term, 23, cooperative reproductive, 29, restorative reproductive, 1. The IVF study is about 1,000 times that. So we have a little bit of a discrepancy in terms of what we can develop a lot more, need to develop a lot more publications and data. So we have a long way to go. These are the areas I hope to see happen in the future. More about motivations, intentions, and behaviors and how they relate to pregnancy rates. Relationships, communication, diet, lifestyle, environment, how that affects the cycle. Simple methods and detailed methods both need to be developed and tested further. Use with medical evaluation and treatment. Microbiome and genomics and proteomics is an exploding area of biomedical research, and it absolutely affects fertility in the women's cycle, and there's a lot to be done there that I hope to see that scientists start doing that. And then the long-term health that comes from cycle optimization. That's it. Thank you.